take it forward. So this specialty you will find will not only reward your curiosity, it will challenge your mind, it will demand precision. Precision medicine is moving in a big way. And today's clinicians, we have so much precision medicine coming with immunotherapy coming, stem cell transplant coming. So you have opportunities in all kinds of healthcare, whether it be tertiary care hospitals, whether it be government hospitals, whether it be healthcare policymakers, whether it be even rural areas, public health. So, on this note, I would like to congratulate the organizers for this initiative of taking small webinars which educate you and familiarize you with what is to come next and officially inaugurate this program. I hope that this inspires many of you to go into hematology for future. Thank you very much for this.
Thank you, ma'am. That was a really, really inspiring words for all of us. And you're very important for the budding hematologist. So, and many, many people who are going to take up this branch of hematology because of your inspiring words. Thank you so much for being our chief guest for today.
There's a lot
Thanks.
of background noise going on, man. People are, I think, unmuted. They're talking.
Yeah, I think
we can't hear
everyone
clearly.
Mute who's not speaking.
Yeah.
Yeah.
So thank you so much, ma'am. That was wonderful, inspiring words. It means a lot to us. Thank you for being our chief guest for the day, ma'am. Thank you so much.
Thank you. Wish you all the best.
Thank you, ma'am. And now, sir, screen is yours.
Yeah, I'll share the screen. Before that, I'd like to thank the Mumbai Hematology Group, Dr. M.B. Agarwal, and all of you for giving me this opportunity yet again. And sorry for missing out last week on the conference. I will start with my screen. Is it visible?
Full screen mode, sir.
Yeah, I'll do that. Is it all right?
Perfect. Yeah.
Okay. So basically, today in the next few minutes, we'll discuss the lymph node biopsy. But before that, I think it's very important that I acknowledge a few persons for turning me into a lymphomaniac. And the first and the foremost is Dr. Kikeri Naresh, a leading figure in the world of lymph node pathology. It was a collaborative work that I was very fortunate enough to work with him when at the turn of the century, we were transforming into the WHO classification. JIPMER, where I worked previously, was a part of that project. And that was my learning curve. I mean, I remember as a postgraduate how lymph nodes used to be so difficult. But working with Dr. Naresh, being able to publish with him gave me the insight into lymph nodes and the lymph node pathology. I would be failing in my duty if I also did not acknowledge the role of Dr. Sumit Gujral, a very close friend of mine, with whom we have done many workshops on bringing lymph nodes to, in fact, very recently also we've been working together. And to top it all, the contribution to my learning was also came a lot from Professor Anita Borges. And it's disheartening to know that she's not there right now listening to my talk. She has been a very, very role model for me. So in all this was my learning, which enabled me to get into the field of lymph nodes. And here I must acknowledge the contribution of all my students, residents, many of them who are leading hematopathologists or hematologists in the country, and their contribution. So if you look at lymph nodes, let me get in the topic. This is Ackerman, and if you read the preface of the lymph node chapter, the word complicated is there. Let me get the pointer right. Yeah, I don't think this word complicated is there in any other tissue chapters or systemic pathology. It is a complicated job. And today my task is to make it a bit simple for all of you. What is in store? I'll first discuss the normal lymph node architecture, the various reaction patterns, and case studies based on morphology and the patterns. Lymph node is a very difficult subject. And so today I will concentrate on the morphology of reactive and benign conditions where they form mimics to a lymphoma. All right, and this talk is going to be purely mainly on morphology and pathology and directed towards the trainees, the students who are looking at lymph nodes. All right, so when is a lymph node done? When do we encounter a lymph node biopsy? A clinically significant lymph node It's a common clinical finding, which is frequently benign, but there are certain warning signs when a lymph node is big, a solitary lymph node, painless lymph node, more than 2 centimeters in size, or it is located at a slightly unusual positions, like supraclavicular lymph nodes. They are always pathological. Epitrochlear lymph nodes, mediastinal lymph nodes, or it's a part of your generalized lymphadenopathy, hepatosplenomegaly, and hematological disorders. All these are clinically significant lymph nodes. Today's talk will mainly focus on a solitary, and that too a lymph node biopsy. Okay, and how do we solve the problems? The basic question a pathologist asks for first attempts to answer when studying lymph nodes, this is in EOChem, it's a good book on lymph nodes, whether the process is reactive or neoplastic. In routine practice, many more lymph nodes with reactive changes are seen as opposed to lymphomas. However, many of these reactive changes are quite atypical, may mimic lymphomas, making it difficult to differentiate the two. So what are the conditions of benign lymph nodes? One is a group of lymphadenitis, the infectious ones, specific, tuberculosis, toxoplasma, or the non-specific infectious lymphadenitis that is there. Then we have this big chunk of lymphoid hyperplasias, which are antigenically derived. Most of them, the stimulus is immunological, and there's this big pattern of reactive lymph nodes, certain syndromes, like Castleman, Kikuchi, etc. Iatrogenic, some drugs, especially the anti-epileptics, presence of foreign bodies and inclusions can all result in a lymph node enlargement. So this is the dilemma. Which of them is real? Which of them is actual? Which of them is malignant? Which is benign? And in this collection of teddy bears, this is a dog. Okay, the rest of them are all toys. So this is the job of a pathologist, all of us, to identify which is what. Before we start, for any organ studying, the knowledge of the normal lymph node structure and function is essential for accurate diagnosis. So this is a cartoon that talks of the lymph node architecture, basically normal. So we have a capsule, which is penetrated by the afferent lymphatics. Then we have a subcapsular sinus, and we have the follicles, the cortex. The cortex is comprised of either the primary follicle, which when sensitized, as we grow older, becomes the secondary follicle. The secondary follicle has a germinal center and a mantle zone around it. Okay, these capsule sends in thin fibrous trabeculae inwards, and this interfollicular area between the follicles and deep down is called the paracortex. Okay, this is the paracortex. Then we have the medullary sinuses and the cords and the efferent lymphatics. So we will look at it now with a lymph node. So that's it. That's the intact section of an entire lymph node. These are the subcapsular sinus. Here it is. That's the cortex with the germinal centers, and that's the paracortex all over, and that's the medulla. Okay, so let us look at these 4 compartments and try and understand. This is the cortex with its germinal centers. Notice that they are usually round, and there is a gap or space between each of the follicles. That is important. So these are all secondary follicles, because we will just see how it looks. So that's on a higher magnification, a round shaped follicle. This is the germinal center. We identify the germinal centers based on the presence of these little holes or the stars. That's the tingible body macrophages. We also realize in this, if you look at it, there is a circumferential cuffing of mature lymphocytes, which are the mantle zone, and this is the interfollicular paracortex. On a higher magnification, further, we notice this mantle zone all around, small lymphocytes, and the germinal center, and the tingible body macrophages. Further, higher power, let's look at it. Notice something. This is the mantle zone. A germinal center has a polarization. What do we mean by polarization? There's this dark zone and the light zone. The dark zone comprises of the centroblasts, and the light zone has centrocytes, small cells, along with a lot of interdigitating reticulum cells, the Langerhans cells, and these are the tingible body macrophages. It's a very proliferating zone where a lot of proliferation takes place. So as there is proliferation, there is also tissue death, cellular death, and the macrophages have a field day in mopping it up. So this, looking at this, there are three important points which helps us understand what a reactive or a reactive germinal center is: the cuffing, the polarization, and the presence of tingible body macrophages. There are various players in the game. And now why lymph node is actually so difficult, because all of them look, lymphocytes, how much different can they look from each other? But yes, if you pay close attention, these are the naive lymphocytes, or the lymphocytes that are present at the mantle zone. Okay, either the unsensitized or the sensitized, they look small, dark, and round in shape. These are the centrocytes, slightly open nucleus, but notice there is a kind of nuclear irregularity, hardly any nucleolus, and they are basically small cells. These become the centroblasts, which are larger cells, and they have a nucleolus which is in the periphery of the nucleus, and 2 to 3 dark nucleolus. Admixed amongst all these are the immunoblasts. Immunoblasts could be in the B zone or in the T zone. We'll discuss that in a while. How do we identify an immunoblast? Is by their usually perfectly round nuclear membrane with a prominent amphiphilic nucleolus, central nucleolus most of the time. So these are the various 4 cells that play a role or constitute your germinal center. So this is an intact node, and this is the immunohistochemistry that tells us where is what. The one on top is CD20, and here is the CD3. So these are the B cells in the follicles, primarily in the follicles, primarily in the subcapsular space, and these are the T cells sparing the follicles and present in the paracortex. If you look at it more closely, this of course is CD20, the B cell population in the follicles. These are the T cells in the paracortex or the interfollicular area. I hope you're aware of some T cells are also present inside the germinal center, the follicular T cells, and what lymphoma comes out of it, we'll discuss in a while. I hope you're all aware of this. So that is how they're immunologically distinct compartments in the lymph node. When we are looking at a reactive node, reactive follicle, few other markers are of importance. This is a germinal center marker, CD10. This, I'm sure you're aware of it, or all of you would be identifying it, which marker is absent in the follicle, but present all over. And it acquires certain significance, and that's BCL2, anti-apoptotic. And this is CD21 or CD23 that highlights the follicular dendritic cell meshwork. So basically, interplay of these 5 groups of immunohistochemistry, a B, a T, a CD10 as a germinal center marker, BCL2 as an anti-apoptotic marker, and CD23 tells you that these is a reactive or a not reactive lymph. Which marker is this? Which IHC is this? This, remember, is the polarization that I talked about. This is a proliferating marker, Ki67. As I said, a normal reactive germinal center is polarized. The centroblasts on one side, which are proliferating, the centrocytes on the other side, which are non-proliferating, not so much. Okay, they have other cells. So this polarization, this distinction of the Ki67 as an immunostain is often used when we have to differentiate a reactive from a neoplastic follicle. We'll come to this in a while. I'm just talking the normal right now. This is the paracortex, right? This is the paracortex between the germinal centers, between the primary cortex is the paracortical area. And this is the hallmark of the paracortex, so the interfollicular area. And these are high endothelial venules. Notice the morphology of the cells. There's a helter-skelter appearance, heterogeneous appearance of small lymphocytes, large lymphocytes, immunoblasts, some plasma cells. This is the T-zone area. And these are the characteristic feature of the paracortex and the high endothelial venules. This is the venules through which lymphocyte trafficking occurs. In and out of the lymph node, that's where the lymphocytes go. So these vessels have lymphocytes in their wall. That's how you identify them from a normal capillary. Secondly, they are called high endothelial because the endothelium is plump, is high, is columnar, rather than the flattened endothelium that we find in all other blood vessels. So this is again a peculiar or a pathognomonic feature that tells us we are dealing with a T-zone area or the paracortex of a lymph node. This lymph node shows the sinuses. The sinuses is through which the lymph flows. They're usually composed of some histiocytes, not very prominent, but always patent. A reactive lymph node shows patent sinuses, whereas a neoplastic lymph node, often the sinuses get compressed, not visible. So that's again another clue when we are trying to identify whether we are dealing with a reactive or a neoplastic process. A few words about one more zone in a lymph node. This zone, or the monocytoid B cell zone, or so-called marginal zone, is not very prominent in a lymph node. It's more prominent in the Peyer's patches in the gut or in the spleen. Okay, now these are the monocytoid B cells, the resting lymphocytes which produce IgM, and they are highlighted or they get proliferated in certain reactive conditions only, and we'll discuss those there. What is the hallmark of these monocytoid B cells is the presence of the small cells and with a clearing around each of them, distinct from each of them, right? So this is another group of normal appearing cells, not so very prominent. This is the marginal zone of a tonsil or marginal zone of a spleen, which is not very prominent in the peripheral lymph nodes, but can become hyperplastic in certain situations. All right. So basically, that's the normal. Like any other pathology interpretation, it's very, very important to have the context of clinical and histological features when we are dealing with. So basic prerequisite, must look at a lymph node with the clinical information, at least the age, the lymph node, the size, number, which region. There's capacity to react is different with different region of lymph nodes, especially the inguinal nodes react very fast, undergo fibrosis, tendency is that. So we must know which node has been removed, whether it's a solitary lymph node or multiple lymph nodes, what is the size of the lymph node, whether associated with hepatosplenomegaly, systemic features like fever. Always have your peripheral blood film report in front of you when you're reporting on a lymph node. All right, that's the essential prerequisite. Okay. Certain technical consideration, whether it's an entirely lymph node, excised lymph node, or a true cut biopsy. I will not go into the true cut biopsies and problems of FNAC in this lecture. I'm going to discuss an entire lymph node. In fact, whenever you are having a problem of a reactive versus neoplastic, it's always good to see an entire lymph node, a resected lymph node, because the reactive changes are so patchy, maybe so patchy, so heterogeneous that it's very difficult to report on a benign lesion or a reactive lesion on a true cut biopsy. Okay, true cuts we reserve for lymphomas. Yes, we can do it. FNACs, yes. But in order to understand the benign lesions, we shall need a lymph node intact. Okay, so and today's my talk is going to be entirely on excision biopsies of lymph node. It's important to have it fixed well. Fixation is important. We'll discuss that. A thin section. For lymph nodes, it's always good to have a separate blade for cutting, for trimming. Please instruct your technicians that to either do it first or do it last with a different blade. You need at least a minimally 3 to 4 micron. Thinner, the better. H&E is good enough for majority of the basis of your interpretation, but you can do IHC, flow, molecular techniques. Everything can be done on a well-fixed, well-stained lymph nodes. So let's look at certain problems that is happening. What's wrong with this? It's a low power view of a lymph node. We know that looking at it, it's very thick, right? So no matter how thick it is, you will not be able to get at a diagnosis. The same section, make it thin, right? Single lymphocytes, and on higher power, you're able to. This is actually the same field where the RS cells are hidden behind the mass of cells, and here it is a lymph node, which is an optimally thin section that is cut. Another piece of advice that I have learned, this is when you're looking at a lymph node in the scanner view, the very low power view, our tendency is to keep everything brightly lit, right? This is under normal illumination of a lymph node. Notice it's not very clear. So always when you're looking at a lymph node in the scanner view or in the low power, the first thing, diminish the light. Let the light be as minimal as possible. Reduce the intensity of light, and you can, all your patterns come out very well when the lymph node is not brightly lit. Okay, so this is obviously a follicular-based lesion, but you would have missed it out if you had kept it at your higher magnification, at your higher illumination throughout. Right, so these were little 2 tips, thin section and properly lit thing. Once you're going into the high power, of course, increase your light, that you need. But only in scanner view, when you're placing the lymph node first, for pattern identification, low illumination works better. Now, when we come to the morphology of the lymph node, Unfortunately, lymphoid tissues have very limited ways of generating a histological response to an agent. Problem, the cells look very similar and their reaction pattern is not very vast. So there are basically 7 reaction patterns: follicular pattern, interfollicular hyperplasia, sinus histiocytosis. The troublesome ones are the diffuse or mixed, where the reaction is anywhere, all over. You could also have a granulomatous reaction or a necrotizing reaction. So we basically have these 7, interplay of these 7, which helps us in the diagnosis. So today my talk is going to be on first identifying the pattern and then following them up. So let's look at the follicular pattern, and notice there is a lot of camouflage that you will see in many of my slides. There is a frog that's hidden amongst the seaweed. All right, so similarly, it is always good to pick out the lesion from amidst its mimics. Right. So what are the causes of follicular hyperplasia? Most of the time, it's an immune paste, right? And there are multiple conditions where you get a florid follicular hyperplasia. Your connective tissue disorders, rheumatoid arthritis, Sjogren's syndrome, SLE. Then specific infection, syphilis, often causes follicular hyperplasia. The initial stage of HIV lymphadenopathy is florid follicular hyperplasia. Toxoplasmosis is follicular hyperplasia. And we have certain syndromes where the primary presentation is with follicular hyperplasia. So let's take some cases one by one. So this is what is follicular hyperplasia, right? Enlarged follicles, but they are perfectly round. They have a mantle cuffing around them, and there is a considerable amount of interfollicular space. So this is a typical, easy to diagnose follicular hyperplasia. What about this? Again, follicles are there. Notice the mantle cuffing. There are increased number of follicles in this. Not all are perfectly round. They have some vague shape, slight variation in shape. That's all right. Interfollicular space is maintained, and the cuffing is there. And notice on looking at them, you see those starry sky, the tingible body macrophages, the empty holes inside the follicles. My bet on this would be reactive. What about this? Intact lymph node. This is where things get dicey. Notice one thing, in follicular hyperplasia, generally the follicles are limited to the cortex, but it's not universal. In this condition, the follicles are present way down into the interfollicular, paracortical, and medulla. So these are the ones that can pose problems. All right, we'll solve them out in a little while. What about this? Multiple follicles, closely packed follicles. And where are they? They are present in the perinodal fat. So this is, in all probabilities, not reactive lymph. This is possibly a neoplastic. Multiple uniform-sized follicles, closely packed with each other, pushing out of the capsule into the perinodal fat, right? So this is possibly, but again, I'm saying possibly. What about this? Homogeneous size, almost uniform size round. I don't see the mantle cell missing. I see the mantle cell is not prominent. I don't see too many tingible body macrophages. Uniform size, closely packed, again, neoplastic. So let's solve this problem. Which one do you think? On the left is reactive, or this is reactive? There are 2 scanner views of the intact node. Okay, we are not interacting. So this one, to me, should be reactive, because you see the follicles are kind of limited to the cortex. We don't see the follicles, as in this particular one, all over. Okay, closely packed follicles, fat infiltrated. So this one on the left is reactive. This is neoplastic. This one. Quite a few follicles, but probably this is reactive. This is neoplastic. The number of follicles are more. They are more closely packed, back to back. Okay. And I'm not seeing a distinct mantle zone around each of them. I don't see the tingible body macrophages. So reactive, neoplastic. Now look at the border of the follicle with the surrounding. Here I'm seeing a well-demarcated mantle zone. The cuffing is there. It's cuffed. It's not intermixed. Here, I don't see the cuff. This is also the border zone. I see many of these germinal center cells entering into it, or the mantle cell going in. Classically reactive. This is possibly not reactive. Then we zoom in onto the cells themselves. Here, These are all very monotonous population of cells. Notice, bulk of the cells are small, slightly angulated, maybe centrocyte-like. This is neoplastic. And here you see the heterogeneous population. Small cells, large cells, immunoblast-like cells, and these macrophages, empty spaces and macrophages. So this is cellularity of a reactive. This is the cellularity of a neoplastic. So what about this? If I see this, I would place my bet on neoplastic. The follicles are present in the perinodal fat. They have moved out of the capsule. So the hallmark of a reactive is the zonation or the polarization. Small and dark, mantle cell. So polarized, that means there is a division between the darker area and the lighter area. The mantle zone is intact, and there is considerable amount of space between each of the follicles. Look at the margin. There is a good rimming by the mantle zone. The cuffing is present, and the cellularity is heterogeneous. So these are the three important features of a reactive follicular hyperplasia. We don't do reticulin anymore for lymph node biopsy, but once upon a time we did. And this is classically the neoplastic follicles have a reticulin meshwork around them. They are rimmed by the reticulin fibers, whereas a reactive follicle is reticulin poor. And you don't have this cuffing around the reticulin, around the follicle on its own, right? So whenever you're looking at a lymph node and you're doubting whether it's reactive, it's good to do the markers CD20, CD3, right? And CD10 tells you that you're dealing with a germinal center lesion, right? Important, whenever you're differentiating a reactive, a florid reactive from a lymphoma, please do a BCL2. Most of the follicular lymphomas stain for BCL2. That's basically 1418 translocation. But mind you, BCL2 is present in a wide variety of all other lymphomas. So it really doesn't help you distinguishing the types of lymphomas. It's only useful in differentiating a reactive follicle from a neoplastic follicle. A reactive follicle is negative, a neoplastic follicle is positive. Of course, BCL2 plays again another role in high-grade lymphomas when you have to differentiate Burkitt from DLBCL. Okay, so otherwise it's used for reactive follicle versus versus a neoplastic follicle. There's no point in doing BCL2 in other lymphomas to distinguish any one of them. Again, Ki67 is important. This is, as I said, reactive Ki67, where the polarization is visible, whereas this is a neoplastic follicle. The Ki67 or the proliferating cells are all over the follicle in a heterogeneous manner. All right. So to distinguish follicular hyperplasia from lymphomas, the age matters. Yeah, most reactive ones are below 40. Elderly patients have lymphomas. As we grow old, reaction as a follicular is not so common. So age is an important thing. Important, of course, you do have childhood follicular lymphomas. That apart, but generally, hyperplasia occurs in young, lymphomas occur in old. Look at the architecture, look for the mantle zone, look for the size, distribution, and shape of the follicles. Heterogeneous are more towards reactive, homogeneous, uniform shaped follicles towards neoplastic. Look at the cellular details, look at the tingible body macrophages, do a BCL2 and Ki67 to differentiate if you need. This was an axillary lymph node resection in a 48-year-old lady, case of CA breast as it had come. This particular lymph node out of the 16 had very prominent follicular hyperplasia. Okay, the rest of them were not. And so just as a thing out of sheer curiosity, we did a BCL2 and it turned out to be positive in a few of the follicles. So this was probably the only case of follicular lymphoma in situ that I have seen. This is an entity that was described in 2002, early events associated with follicular lymphoma. 2.5% of the reactive nodes do have this, and there is a synchronous follicular lymphoma or a follow-up towards follicular lymphoma is described. And it's characterized by a few germinal centers, few of them, not all, which express BCL2 and BCL6 and C, where the rest of the node is reactive. So that's an entity that we come across once in a while, unless we are doing a concerted study on all lymph nodes and doing a BCL2 on them. We won't be able to pick up this lesion. Let's look up some other benign follicular hyperplasia conditions. This is a 20-year-old student who had a solitary node of a long duration. Okay, otherwise no other organomegaly, CBC and PS were normal. And this is what it was. Follicular hyperplasia. But note that one of the follicle is huge, is much bigger and not so well delineated as the rest. Okay, so this is, if you look at it, it's not a very well delineated kind of a follicle. Okay, we'll go into the higher part again. This is another case. Same thing. I just wanted to show reactive follicles, but there is one which is big, vaguely follicular, vaguely nodular, but not so well differentiated or delineated from the rest of the tissue as these ones. Here it is. Here, if you notice, in this particular one, the dark cells or the lymphocytes are kind of infiltrating inside the follicle. You don't have a nice, clear-cut germinal center zone. This kind of a lesion, again here, notice the mantle cell, the one that cuffed, is now entering into the germinal center. This looks like a reactive germinal center, right? But here you see a bit of a mantle zone that is infiltrating into it. So this is an entity that's called progressive transformation of germinal center, often seen in young males, presents with a solitary node. Some of the follicles are big, more than 4 times the rest. The background is typical of secondary. These are BCL2 negative. Enlarged follicles that are encroached on by mantle cells, and therefore they are IgD positive. They are rich in follicular T cells, often have PDL1 and CD57 as markers. And they sometimes are known to be coexistent with nodular lymphocyte predominant Hodgkin lymphoma. And that is an important differential diagnosis for this lesion. We have another case, a 43-year-old woman, fatigue at weight loss, presented with a mediastinal mass and a big node of, again, a long duration, no organomegaly. Again, notice multiple follicles, looks benign, looks reactive, most of them, right? But they're of a varying shapes and sizes. Here, if you look at this, what is prominent here is this cuffing by the mantle zone. Very, very prominent, almost like an onion skin pattern. And there are these germinal center cells, which are kind of atretic. Again, beautifully onion skinned. And notice all these high endothelial vessels, there's kind of looking into it, entering into it. Those who have seen this condition would be able to diagnose it. Again, extremely atretic follicle, hyalinized follicle, and there is a little bit of a vessel that is kind of protruding into it. And most of it is made up of those mantle cells. Beautiful. It's called lollipop appearance. A vessel entering into the germinal center and surrounded by a rim of small cells. At times, you find this phenomenon of twinning, that is more than one germinal center inside the cortex. Okay, rimmed by the mantle zone. This one has 1, 2, 3, 4, 5. They are germinal centers, but there is a conglomeration of germinal centers in it. Another one, this is on a low power. Again, notice all the germinal centers, the cells are not there. There are too many blood vessels, and there is kind of a follicular atrophy. Another one. Okay. At times, the paracortex is infiltrated with lots and lots of plasma cells. Okay. So what is this diagnosis? This is Castleman disease. Current classification of Castleman is unicentric. It's based on unicentric mediastinal, idiopathic multicentric, and it is related to Kaposi sarcoma herpes virus, HHV8 related multicentric. This is a viral induced disorder. It has now come under the WHO classification as mimics of lymphoma. I'll just talk about that in a while. Histologically, there are 2 variants, a hyaline vascular type, which I showed you the most of the slides, hyaline and vascular. And the second one is the plasma cell type. And there are many syndromes like Boehm's or Tafro associated with Castleman disease. Both these are kind of malignancies, but not so. So currently, it's believed that Castleman has a clonal entity. Just come to this in a little while. We have another case of a 28-year woman, abdominal pain and diarrhea, with multiple left cervical nodes. And in addition to that, she had eosinophilia with an absolute eosinophil count of 3,500. Again, follicular hyperplasia, big follicles. Most of them were reactive, excepting for this 1 or 2, which showed a bit of a follicular lysis. And if at all, you can make out on low power, and this magnification is eosinophils. Too many eosinophils infiltrating into that. The paracortex was rich in these high endothelial venules, very prominent, and lots of eosinophils in these vessels. There were areas which resembled almost an eosinophilic abscess. This was inside those two germinal centers, almost just filled with eosinophils. And here and there, we were able to spot some multinucleated cells. So this entity is Kimura's disease, probably allergic, seen basically in Asians, Southeast Asian, young to middle-aged male, with a triad of follicular hyperplasia, vascularity, both in the germinal center and the paracortex, and eosinophils. And this is a disease which a differential diagnosis of eosinophilia. Drugs can cause, parasitic infection can cause, and certain malignancies you're all aware of, I'm sure Hodgkin's, PTCL, often have eosinophilia. So this is a combination of follicular hyperplasia with eosinophilia. Coming to the last of the reactive ones, 51-year-old lady with multiple cervical lymph nodes, raised ESR, again, follicles, not very prominent, slightly in the background, but definite follicular hyperplasia. A lot of vessels. Vasculature at places bordering to even obliteration. You really can't make out the lumen of the vessels. They're so proliferating in them. And notice here you can see tremendous amount of plasma cells. This case, I'm thankful to my former colleague, Dr. Srirekha. We published this entity, our first entity that we had seen of this. In addition to that, if you notice, there's some kind of fibrosis, hyalinization and fibrosis within the lymph node. It's not a very normal looking lymph node. CD20 positive, CD3 positive and reactive, both 20 and 3 were like a reactive. There were a lot of plasma cells, CD138 positive, IgG positive, and IgG4 positive. Okay, so we were dealing with an entity that my good friend, Dr. Vikram Deshpande, has identified as an IgG4 related disease. It's a systemic fibroinflammatory condition with dense lymphoplasmacytic infiltrate, fibrosis, and obliterative phlebitis, common in the pancreas, common in the salivary gland, common also in the lymph nodes. So the dilemma of a follicular pattern is this florid follicular hyperplasia, persistent transformation of germinal centers, Castleman, Kimura's, IgG4, and you've got to differentiate these from these two entities, a follicular lymphoma and a nodular lymphocyte predominant B-cell lymphoma. Right. The WHO-5, if all of you, those who have read it, now includes the mimics in the entire classification. And there are these tumor-like lesions with B-cell predominance, IgG4 disease, unicentric Castleman, idiopathic multicentric Castleman, HHB-associated Castleman, and reactive B-cell rich lymphoid proliferation that can mimic lymphomas, persistent transformation, progressive transformation, infectious mononucleosis-like condition, lupus lymphadenitis. So all of these are now a part of the classification system of lymphomas. We have identified that there are mimics which have to be excluded before we diagnose a lymphoma. Another problem with identifying lymph nodes is primary follicles. They look very small, and you may mistake it for a small cell lymphoma group of conditions. Be careful about that. And to top of it all, if your slides are poorly fixed, tissue is poorly fixed, even the largest of lymphomas will look small. So be careful about these two primary problems, primary follicles and a poorly fixed lymph node. Okay, so all these can be part of your diagnosing the mimics. Let's move on to the paracortical or the interfollicular hyperplasia. This is the area, right? This is the area that we now concentrate on. Cortex, follicle, and this whole area. Few important points about a normal paracortical area is that it's heterogenic, the cellularity is heterogeneous. Okay, lots of cells are there, small cells, large cells, immunoblasts, plasma cells, a stray eosinophil, everything can come in, and also its vascularity. The high endothelial venules, you will also get a smattering of the reticulum cells also over here. So we have this 57-year-old lady, right axillary lymph node. She had psoriasis for a long time of the right hand and the nails, and she had a pretty large node. And this is what it showed. The paracortex was expanded, paler than the rest of it. And this is again another area. And notice the histiocytes, the vessels, the proliferating, more of histiocytes than the lymphocytes. And if you look carefully, you're going to find pigment. Right? Pigmented histiocytes, lot of interdigitating reticulum cells, your Langerhans cells, and your lymphocytes. So these are all a part of it. And also notice the blood vessels. So this entity is called dermatopathic lymphadenopathy, a benign condition. Pale staining areas of interdigiting reticulum cells, Langerhans cells, histiocytes. And the pigment is a mixture of melanin, certain lipids, and hemocentrin, predominantly melanin. It can be seen in chronic exfoliative skin conditions. But the dilemma is when you're dealing with a lymph node biopsy in a case of confirmed mycosis fungoides, as you know, stage 1 lymph node involvement is dermatopathic. So in such situations, you may have to assess for clonality, CD3, CD4, CD8, and if necessary, even T cell receptor studies. In certain situations, in this condition, it's actually a very, very difficult area at times. 13-year-old girl, fever, lymph nodes, very similar to the past cell. The intercortical area is pale. She also had eosinophilia. Look carefully now at those pale cells. It's kind of spindly, full of them, with a few smattering of lymphocytes and eosinophils. Look carefully and your diagnosis is made. All of you, finally, are postgraduates or residents. I should be able to make your diagnosis by looking at these cells, the typical grooving of the coffee bean. Okay, coffee bean appearance. So, coffee bean appearance. Okay, so that's, and if you marker-wise go ahead and diagnose Langerhans cell histiocytosis, CD1A or Langer, whatever you want to do. 19-year-old male, another one, cervical lymph node, where also has splenomegaly. Again, notice the paracortex is wide. The interfollicular area is huge. Look carefully, again, the cells. Now here you see not just histiocytes, you see atypical cells. And this is almost resembling the hallmark cell or the fetiform cell. So remember, certain lymphomas may have not the entire lymph node effaced, but partial effacement. You do your marker, CD3, 5, EMA positive, CD30 positive, ALK1 positive, and you diagnose anaplastic large cell lymphoma. The basic pattern or morphology remains the same. Paracortical or sinusoidal pattern with partial effacement. That's typical of anaplastic large cell lymphoma. They are CD30 and ALK1 positive, all right? But remember, amongst all the lymphomas, almost 50% are positive for an epithelial marker, and up to 40% may be negative for a leukocyte common antigen or CD45. So it's an important diagnosis to be made and not to be missed amongst others. Similarly, another lymph node in a 24-year-old girl. Again, notice the germinal centers are here, but the cortex, the interfollicular area is widened. And if you look carefully against them, background is lymphocytes, few high endothelial venules, but there are these two large cells. Not typically, but large cells. So what you will do now in this situation is CD30. Notice how beautiful it's a case of Hodgkin lymphoma, and how beautiful the CD30 positive cells are surrounding the germinal center. CD30 positive, CD15 positive, PAX5. So this entity is what is called an interfollicular variant of Hodgkin lymphoma. It's an early phenomenon, partial effacement, and can be a mimic. A 4-year-old boy, bilateral cervical. Again, the area is all interspersed, and here, follicle, and you have this kind of a thing. Look at it carefully. Round cells. Let's look a bit more carefully. Under higher power, and you see these neuropil. You see the round cells. Here is a nice rosette formation. Do an LCA, and that highlights the normal cells, normal reactive population. Do a chromogranin synaptophysin, and you're diagnosing a metastatic round cell tumor. So on one hand, we have a relatively benign lesion of a dermatopathic lymphadenopathy, and on the other hand, we have all these gruesome lymphomas and things. Jaffe has said, diffuse paracortical proliferations are probably the most difficult benign lymphadenopathies to differentiate from lymphomas. Often a subtotal effacement and presence of immunoblasts with atypical cytological features. One of the biggest mimics or problem that creates is a viral lymph node. Thankfully, we don't do a lymph node biopsy for most viral infections, as they are self-limiting. But if you have to do, look at this. This is obviously the paracortex with the high endothelial venule. And look at these cells, almost resembling a Reed-Sternberg cell or an atypical immunoblast, right? Yeah, they are also, unfortunately, CD30 positive. The viral immunoblasts are CD30 positive, but with Epstein-Barr virus, either LMP or Eberish, you can pick them up as viral. This is again another entity in itself, another topic for discussion, which will take long. I'll not go into the details of it. Thankfully, in infectious mononucleosis, we normally do not subject because they have a large number of immunoblasts with a reactive background and they are positive of CD30 and Epstein-Barr virus, both as immunohistochemistry or Eberich, often gives you the diagnosis. This one is mine. The rest of them are not my cases. But notice that the superficial kind of resemblance to Reed-Sternberg cell, CD30 positive, and none of these are Hodgkin lymphoma. If you read Jaffe, atypical cells should be evaluated in the company they keep. Cells mimicking Reed-Sternberg cells can be seen in many non-Hodgkin lymphoma and reactive viral conditions. So the dilemma of the paracortical hyperplasia is viral infections. At times, yes, even anticonvulsants, phenytoin, can cause a large lymph node with paracortical expansion, dermatopathic lymphadenopathy, and many, many lymphomas and other malignancies. The sinusoidal pattern. This is relatively easy. This is typical sinuses dilated, which you find in a lymph node draining a metastasis. May not have metastasis, but draining a malignancy. Lymph nodes often show sinus histiocytosis. And that's how it looks like. But there is one entity that comes up when we're dealing with sinus histiocytosis, a male with a large bilateral, big nodes. Look at the sinus expansion. Look carefully under them. Apart from the histiocytes, there are very large cells. I'm sure all of you looking at it would be able to diagnose it. There's emperipolysis in the macrophages, and that is a diagnostic feature of a Ross-Hoffmann disease. Sinus histiocytosis with massive lymphadenopathy. Okay, and these histiocytes, CD68, 163, S100, cyclin D1 positive, negative for the Langerhans cell markers. Okay, I remember the first Ross-Hoffmann that I saw when I was a PG. I don't know if Dr. Uma, you're listening to this, but it was a Ross-Hoffmann of the eyelids. That little boy used to come and lift up his eyelids. You know, it had such a big proliferating eyelids. We saw emperipolysis, given steroids, and he recovered. Other important issue of a sinus pattern is metastasis. Okay, always look for, when you are screening for metastasis in a dissection specimen, radical neck dissection or axillary node, look at the subcapsular sinus. That's where the metastatic focus comes in. Okay, so this is metastasis. Any form of metastasis can be there. Often not involve the entire node, but partially involved. Look at the subcapsular sinus and sinuses, and you will pick up metastasis. Those from JIPMER may remember this slide. This was the case of filarial lymph node. Again, the sinuses are chopped. This is what was shown to the undergraduates once upon a time. I don't know the significance of it, but yes, filarial lymph nodes, always the subcapsular sinus and the lymphatics may be positive. So the dilemma of the sinusoidal pattern is sinus histiocytosis, Ross-Hoffmann, metastasis. Amongst all the NHLs, ALCL is one mimic. It can have sinusoidal presentation also and filariasis. Other patterns that can cause problems, and one of them is granulomas. We think granulomas is easy, but no. At times they can. Lymph node with such granulomas. Yes, caseation, coalescing granulomas, well, tuberculosis, fine. But tuberculosis itself can have a myriad patterns. There could be non-caseating granulomas just with epithelioid cells or foamy macrophages. They could be just, you can't even make out the circumscription of this granuloma. They are evenly spread out here and there. Be careful about such histiocytic aggregates. And suppuration. There is a granuloma here. You can make out the histiocytes, the activated macrophages, but it is interspersed with lots of neutrophils and debris. So tuberculosis, depending on the immune status of the individual, depending on the bacillary load, can have a wide variety of presentation. So when you're discussing or dealing with a tuberculous lymph node as a resident, when you're looking at it, always, especially when you don't see typical caseating granulomas, ill-defined granulomas, please do an acid-fast bacilli. It's usually positive because it reflects the immune status. A well-formed granulomatous tuberculosis, you may may not pick up the acid-fast bacilli. But when the granulomas are atypical, granulomas are more ill-defined, more of foamy macrophages, lot of suppuration, that indicates the immune status is low and bacilli can be easily picked up. We are aware of the causes of granulomas: non-infectious sarcoid, berylliosis, malignancies like Hodgkin's, there may be a reactive granuloma formation. Even in draining neoplasms, draining malignancies, you get non-infectious granulomas. Infectious could be broadly classified as non-suppurative or suppurative. Non-suppurative is tuberculosis, leprosy, atypical mycobacteria, and fungal, where you don't have breakdown, when you don't have pus or don't have neutrophils. Suppurative granulomas, classically cat scratch, LGV, lymphogranuloma venereum, or Yersinia pestis. We are also often asked this question of differentiating between tuberculous and sarcoid granulomas. This is just for your residents. Sarcoid granulomas are discrete. The tuberculous ones are coalescing. The sarcoid granulomas are naked. They don't have too many lymphocytes. They are well admixed with lymphocytes. The sarcoid granulomas have giant cells, asteroid bodies, Schaumann bodies, calcification, and less of epithelioid cells. Whereas in non-sarcoid or tuberculous, there's lots of epithelioid cells, less of Langerhans giant cells. Calcification plus minus could be there. Generally, sarcoid granulomas do not reach the capsule, whereas these cause perinodal spread. And that is why you have tuberculous lymph node, which mats. Matting is because of this perinodal involvement of the granulomas. One lymph node spreading onto the other lymph node. No caseation in sarcoid. Caseation, yes, one of the very important features. Sarcoid granulomas are supposed to be reticulin rich, but these have poor reticulin. Whatever little reticulin the lymph node has gets lost with the granulomatous formation. So this is a classical sarcoid granuloma. Okay, and we have these asteroid bodies, Schaumann bodies, kind of well-formed, naked, without much of lymphocyte cuffing. This one, we are quite sure it looks like sarcoid. Look at the giant cell, sarcoid. Look at the calcification, but one of the granulomas showed caseation. So tuberculosis is a good mimic. Not all, everything is not black and white in pathology. 21-year-old man, HIV positive. We had these large multinucleated giant cell-like granulomas in this. You're wondering, closer look, we identified the basophilic yeast forms of Cryptococcus, which got highlighted by a musicarmin stain. So any of these fungal organisms can cause granulomatous reaction. What is this finding? What kind of, if you were to look at lymph nodes and you saw these little pale areas, few collections of them, this is what is known as a microgranuloma, less than 25 epithelioid cells in collection. And this is a hallmark of certain diseases like toxoplasma. It's also seen in the granulomatous reaction towards Hodgkin's lymphoma, especially Lynette lymphoma of the T cell type, and in metastatic. You may get small collections of epithelioid cells, microgranulomas. This was a case Manish would remember, a 75-year man with cervical and axillary lymph nodes. The first biopsy we saw was just this. Small aggregates of histiocytes, epithelioid-like histiocytes, even beautiful Langerhans giant cell. We labeled it as a granulomatous lymphadenitis, but we were not happy with the diagnosis. Neither were the clinicians, because there were big nodes, big bulky nodes this patient had. They repeated a lymph node biopsy, and this is what we saw. In that lymph node, a few granulomas, but bulk of it had these, I'll show you further, atypical cells, lot of vascularity, eosinophils, high endothelial venules, clear cytoplasm around the vessels. CD3 was strongly positive, CD4 was positive, 20 was sparse, CD10 was positive, and CD23 showed these expanded germinal centers. So diagnosis, we called it angioimmunoblastic lymphoma, mimicking, microgranulomas mimicking angioimmunoblastic lymphoma. We know that entity doesn't exist anymore. It's called a nodal T follicular helper cell lymphoma. And this is where, if you remember my initial slide, the T cells that populate the germinal center. This is a lymphoma that arises from that. So it's seen in elderly, CD3 and CD4 positive. They have a follicular helper T cell expression, expanded CD23 positive things. Okay, and this is an entity, often has an extranodal involvement with spleen, liver, skin lesions, etc., and EBV related. A 20-year-old boy, fever 3 weeks, shorty cervical lymph nodes. This sample came to us, the specimen slides came to us with a diagnosis of Hodgkin's. I'll tell you why. Notice the type of follicular expansion, map like bizarre, they're not round, extremely bizarre shaped follicular hyperplasia. And what is this? Just below the capsule, the monocytoid B cells. Very prominent, monocytoid B cells prominent. That's a reactive germinal center. And notice these microgranulomas, all of them encroaching on the germinal center. Okay, this is very beautifully seen. Small collections of epithelioid cells into the mantle zone. That's the germinal center here. High part of that. Germinal center with the tingible body macrophages, that's the mantle. And there are these epithelioid-like cells which are encroaching upon. Diagnosis? Toxoplasmosis. Often presents with fever, lymphadenopathy, and triad of follicular hyperplasia, monocytoid B cell hyperplasia, and microgranulomas. Necrosis can be troublesome. A classical 18-year-old girl, fever, sore throat for 1 week with a left cervical lymph node. The node was very big. That's why it was excised. Shows geographic necrosis. This area looks quite normal. Little one patch of necrosis, pale area. Okay, again, we'll look at it under hyper. Again, I'm sure those of you who look at lymph nodes will be able to make out what disease we are talking about. Look closely at this area, the necrotic cells. Look very close again. You see a lot of nuclear debris, apoptosis. Whenever there is a necrosis, I would expect some neutrophils to be there. There are none. So hardly any neutrophils, but these patchy necrotic areas with apoptotic debris, nuclear debris only. And this is a hallmark of Kikuchi Fujimoto. At places, it may have a lot of proliferating blast-like cells. So it could be a histiocytic, could mimic a lymphoma. So this is again typically surrounding the areas of necrosis, you will find this. So this is Kikuchi Fujimoto. And again, this has come under the WHO5. Tumor-like lesions with T cell predominance. We heard about the B cell, and this is a new class of tumor-like conditions. Large aggregates and sheets of T immunoblasts and histiocytes accompanied by nuclear debris, prominent apoptosis. CD123 positive, and many of these histiocytes express a myeloid marker, myeloperoxidase. No granulocytes should be identified. It mimics lymphomas with a strong differential diagnosis of lupus lymph node. And this is what we'll see now. A 39-year-old lady, arthralgia, being investigated for a connective tissue disorder. She had a big node, and that again shows necrosis. Few debris, but notice there are a sprinkling of neutrophils here and there. In addition, large atypical looking cells, histiocytes, nuclear debris, apoptotic bodies. And on a closer look, you had these areas, basophilic areas, what are called the hematoxyphal bodies were identified. Not in all would you see. Typically a vascular component with fibrinoid type of necrosis, basophilic necrotic material. That's the hematoxyphal bodies. And you diagnose a lupus lymphadenopathy. It indicates activity in a case of SLE. Usually cervical or axillary node may antedate the diagnosis of SLE by years. And it often resembles a Kikuchi Fujimoto, excepting for the neutrophils. Another 9-year-old boy, fever and axillary node. Look at the necrosis. You can identify it on low part. Very patchy kind of a necrosis. Here there are lots of neutrophils. Whenever you see patchy necrosis, lots of neutrophils, think of a disease called cat scratch disease. Ask for history whether there are cats at home. In this case, it was. And you can do a Warden study and identify the organism. Necrosis is very similar to Kikuchi, stellate shaped with a lot of neutrophils. Periphery may show granulomas. And do a Warden study stain for the Bartonella species. Again, another lymph node. That's a mimic now. Lots of arborizing kind of necrosis. On higher magnification, look at them. They are atypical lymphoid cells. CD20 positive. So this is a DLBCL that showed patchy necrosis. 75-year-old man, cervical lymph node. Look at the vessel that is kind of necrotic. We were thinking of possibly, are we dealing with an SLE or something? This is typically centered around the vessels. When we look carefully, the cells are all atypical. Yeah, atypical cells around the vessels. Around the vessels, you do a marker, CD3 positive, CD56 positive, and you diagnose nodal NK cell lymphomas. So necrotizing lymphadenopathy can be seen either with an infarcted node, often follows FNACs. We have seen that. Kikuchi Fujimoto or lupus. acute suppurative lymphadenitis, necrotizing granulomatous, classically cat scratch or LGV. Tuberculosis may be necrotic. High-grade lymphomas can show necrosis. Just last word on HIV-related notes. We are not getting this too frequently nowadays, but as you know, persistent generalized lymphadenopathy by CDC was that you should have a lymph node of 3 months duration, absence of any drug or infections, and often present with reactive follicular hyperplasia of 3 patterns, initially a very florid, and then follicular lysis and atrophy. You can get certain infections, especially mycobacterial infections, which is the commonest, and you must pick up an HIV patient lymph nodes may have Kaposi or a lymphoma. So this is a typical florid follicular hyperplasia. Look at the bizarre shape of the follicles, but all characteristics of reactive is identified. This is followed by certain amount of follicular lysis, depletion, atrophy, and you cannot really make out the follicles well in pattern C. You can see this aberrant kind of transformed vasculature here in an HIV positive patient. Here you might have to differentiate it from Kaposi's or other conditions, but this was a kind of a reactive change that is seen in very infrequently in HIV lymph nodes. This particular patient, notice, has a very florid, mixed kind of reaction, no definite follicles, no paracortex, sinuses were not seen. And if you look at them on high power, they're all spindle-shaped cells. Do an HIV, again, high power, they all could be Langerhans cell, could be histiocytes, epithelioid, do an HIV, and typically you find them in the histiocytes in the cytoplasm, something akin to a histoid leprosy in the skin, and this is what is called the spindle cell mycobacterial pseudotumor. On the other hand, at times there is a infiltration by foamy macrophages rich with acid-fast bacilli, mycobacterium, avium intracellular in the lymph. So that's the dilemma. That's a tree bark with an owl in it, very difficult to pick up. So you need to have the differential of a reactive lymph node from a specific lymphadenopathy, infective lymphadenitis, lymphomas, and other malignancies. All of these form a gamut of diseases that cause mimics of lymphomas. So to summarize, pay attention to the morphology of reaction. That's very, very important. First step. Look at the cellular details. Most of the reactive ones have normal histology. They may be a heterogeneous population. ATPI is not so prominent. Look for necrosis, look for granulomas, look for suppuration. Stain for microorganisms if indicated. IHC, especially with mixed pattern and interfollicular. You may need it also for your follicular hyperplasia versus follicular lymphomas. And it is always an integrated, with good clinical input, serology, virology, imaging, and hematological parameters. So thank you all for a patient hearing, and my tribute to the 2 institutes that I was and currently I am. And that actually is a lymph node biopsy. Came in the routine, heart-shaped, fine. So that's it for now.
Thank you so much, sir. Fantastic lecture.
Sharing. Yeah, I'll
as
stop
always.
sharing.
Granulomas and basically and we assume these sarcoidosis, and there are as you also mentioned that it's a very close differential diagnosis with the lineage lymphoma. Now sometimes though you have mentioned the differences between both of them, but are there any is there any specific CD4 CD8 ratio or aberrant T cell marker loss like CD5 CD7 that triggers you to stain for that T cell lymphoma in every granulomatous node, or do you reserve that case for the specific cytological?
No, every granulomatous node I would not think of T cell lymphoma. If your granulomas are coalescing, large granulomas with necrosis, no. unless it's a
Sir.
coexistent disease altogether. But the problem arises when you have these subtle microgranulomas interspersed everywhere. And then, of course, if you have to diagnose a T-cell lymphoma, you must have the entire panel of immunohistochemistry for T-cell lymphoma, aberrant expression or downregulation of CD5 or CD7, CD4, CD8 ratio. But that I reserve for cases which are really a diagnostic dilemma. A straightforward case of granulomatous, I would not look at it, right? You understand, I'm sure with your experience also, you will know where you have to really look for the immunohistochemistry in details. And T-cell lymphomas is one where you may even have to do a T-cell receptor assay if you're really going to, because that is one of the trickiest lymphomas to pick up, agreed. But it doesn't mean that every time I see a granuloma, I would put up the entire marker for T-cell lymphoma.
Sir, what's your experience? Because we are doing in the sample, we are getting the samples, and we are ourselves doing the FNAC and with the flow cytometry. Likewise, we have catch hold upon the follicular lymphoma, the mantle cell lymphoma. Are there any other lymphomas wherein the flow cytometry can take a major role? Because the turnaround time and the all those things, because
I did not cover that aspect today. I thought of just limiting myself to benign, because that's in itself. Yes, we have also good experience with flow cytometry, being able to pick up follicular on either even not on a cell block or flow cytometry and putting it up for flow. It is working out. We are getting out good cases, even DLBCL, etc. We've been able to pick up on flow. Yes, it is there. It is taking over. I did not personally go into that area today at all. I just thought I'd limit myself to
because the topic is so vast that we can't cover each and every aspect.
Yes.
Sir, last question, sir. Sorry. Sir, do you find any post-COVID changes in the lymph node biopsy? Because I have seen like paracortical expansion and florid immunoblastic proliferation. So, do you find any changes? And because they are again a mimicker of the malignancies. So, what's your experience in that, sir?
I wouldn't have too much experience post-COVID because I shifted out of JIPMER where I used to get a good load of lymph nodes. Whatever I have seen now is basically from literature. But yes, we are getting reports of post-COVID lymphadenopathy, which are not really malignant, but showing a viral kind of a thing. I don't have personal experience too much on post-COVID lymph nodes.
Sir. Thank you, sir. Thanks again, sir. Very beautiful lecture,
Thank you very much. Thank you.
Thank you, Dr. Ankur Ahuja. Dr. Rashmi Kushwaha, your question.
Good afternoon, sir. It was a wonderful class, and it was really a delight to see all the cases having the excisional biopsy. At our center, we usually get the core biopsy, and life is very difficult with the core biopsies because it is like...
Yeah, agreed. Encourage, whenever you're thinking of a reactive process, a biopsy, it's ideal to get an entire biopsy. Because as you know, the reactive changes are so heterogeneous, so much focal, so much on a core, it is very difficult to pick up reactive changes. And yeah, I personally would go in but I know with passage of time, with advancement in our imaging techniques, core biopsies are coming up. But I'm not very confident of reporting reactive nodes on a core biopsy. I'm confident of reporting lymphomas on a core biopsy with my IHC panel, yes, better. But none of the reactive lesions you can really pick up on a core biopsy unless you have an obvious granuloma or something.
Yes. And sir, like recently we had a case of DLBL which had relapsed after the chemotherapy. So second biopsy was done around few months back, and again it was suggestive of DLBL. But this time CD5 also became positive in it. Initially 5 was negative. Now, third time we have again received the biopsy from the lymph node biopsy from the same case, and we are seeing the multiple non-caseating granulomas, which are having only histiocytic collections, not even so many lymphocytes. So again, we are in a dilemma whether both the things are coexisting or it is only the granulomatous lesion which has come up now because of the immunocompromised state of the patient.
Could be anything. Could be anything. Could also be just a part of the reaction to the therapy. Granulomas in a lymph node could be multifactorial. So you'll have to probably go in for the usual approach to a granulomatous.
Okay.
It need not be it could be tuberculosis because of low immune status. So it is difficult. It's a difficult area. I don't know. It needs a lot of clinical and other investigations to support
Inputs
your
and
diagnosis. Very true.
yes.
Post
Thanks
therapy,
a
we
lot.
have seen granulomas. Post therapy, we've seen granulomas, not just in lymph nodes, even in bone marrows and all leukemia cases. Post therapy, we have found just a granulomatous reaction.
Okay. And so these granulomas, like which are chemotherapy induced, are usually different from the normal granulomas because they have less of lymphocytes, I think,
Yes,
in them,
yes.
and more of
They kind of
macrophage and
resemble the sarcoid type of granulomas
sarcoid
more than they
granulomas.
resemble the.
Okay. Thanks a lot, sir. Thank you.
Thank you. Sir, from the same note, I have a question for you. Can follicular lymphoma be diagnosed by core biopsy?
I find it difficult. If you get a good follicle, you could. I mean, I don't know. I'm not very confident of diagnosing on core biopsies. People are doing it. I am still a hardcore old timer. I need the full node.
Thank you, sir.
Only I would reserve core biopsies for only inaccessible or very big nodes. Otherwise, convince your clinicians to take the whole node out.
Perfect.
Difficult.
Dr. Rama, your question.
Good morning, sir. That was a beautiful lecture. Thank you. I have a question, sir. AITL versus NK T cell lymphoma and lymph node biopsy. Because when you showed one case of nodal NK and you were telling that around the blood vessels it is there angio-invasive, angio-destructive. That will happen even with the AITL, right, sir? So are there any
AITL
morphological
doesn't have
things?
so much of angio invasion. They surround the vessels, but the typical necrosis of angio invasion is not very often seen with AITL. AITL cells are that way more bland. NKT cells, as you know, cause
They're
angio invasion
destructive.
and hemorrhagic kind of necrosis. That is it. Otherwise, yes, it's.
As such, we
all these
can't find in the morphology.
No, difficult.
Yeah.
That's why
Thank you,
for
sir.
lymphomas and all, morphology is just the base, which will help you determine which type of antibodies to give. What is your IHC panel?
Okay.
Currently, lymphomas, you cannot diagnose just on morphology. But having said that, most of these benign lesions, you can diagnose on morphology. It's only the tricky ones, and I have shown the tricky ones. Those actually are not too many amongst, if you look at the entire gamut of reactive lymph nodes. I have just presented the tricky ones for the sake of presentation and I mean, sharing with you the problems that we face. So it doesn't mean that for all reactive, you're going to do a panel of antibodies. That's not indicated.
Yeah, one more case was like an eye-opener, sir, that you showed the large areas of necrosis, but you told it is a case of DLB cell.
Yes,
so we need to
yes.
search for that.
100%. You have to look at the morphology very, very carefully.
So scanner, if we take it off like granuloma, done.
No.
Expectation.
That cannot be done. You have to pay attention to morphology. Yeah,
Okay,
sure.
thank you, sir, for the beautiful cases.
Thank you. Thank you so much.
Thank you, Dr. Rama. There is one question from Dr. Gopinathan. How common is to get Kikuchi Fujimoto in abdominal lymph nodes?
Not very common, I suppose. Not very common. I have not encountered any Kikuchis till date with an abdominal node. Most of the time, it's cervical. Young females is the standard. I don't think I have any in Kikuchi in our series with an abdominal node.
Thank you.
There's no harm in, I mean, I don't see it not happening. It can happen. I don't know. Okay, sir. So we have always a big question about double expressor and double hit lymphomas. I would rather not touch that right now because it is not a part of this, So let's stick to benign and let's stick to it's difficult, double expressor, double hit doesn't come under this purview. So only the question is very simple by Dr. Gopinathan that whether there is any disparity between BCL6, BCL2 and MIG on IHC and FISH. Do you get a disparity? Yes, it has been reported. It is there. It is there. FISH is definitely better than IHC. Or either way, whatever. Yeah, it is there. Thank you, sir. Another question is from Dr. Tara Roshni Paul. How do you differentiate CD30 positive immunoblast from mononuclear RS cells? Yeah, that is important. That is, again, morphologically, if it's an immunoblastic proliferation, they are always in groups. One, generally RS cells are scattered. Typical RS cells are scattered unless it's a lymphocyte depleted or not. Morphology is useful. Mononuclear immunoblasts are very uniform looking, most of the time mononuclear. The RS cells always have a company, you'll find the mixed inflammatory infiltrate, binucleation here and there, looking at it. Otherwise, it's purely then If all that is very similar, you will have to do your CD30, CD15, PAX5. PAX5 in RS cells are weak. The immunoblasts, B cell immunoblasts in PAX5 would be strong. Immunoblasts are usually CD15 negative. RS cells are, quite a few of them are CD15 positive. So look at the morphology, and then at least these three panels should help you. Sometimes the reactive immunoblasts could be T cells. So those immunoblasts which are CD30 positive could be T cell positive, unlikely to be an RS cell. So you have to use your...
Paxide would help in this case, sir.
Yes, at times, yes. I find PAX5 is a very good, good stain. The typical weak positivity in Hodgkin
RS
can be, when you're comparing it with the surrounding B cells, it's a very useful stain to look at.
Thank you, sir. Another question from Dr. Jyoti Sawhney. How do you differentiate between marginal zone hyperplasia from nodal marginal zone lymphoma?
Okay. Nodal marginal zone lymphoma would be rather uniform, diffuse all over. Most of the follicles would be surrounded by marginal zone. Marginal zone hyperplasia is generally focal. You don't have, like I showed you, whatever cases I've seen, it's only a focal area where there is hyperplasia going on. And then, of course, clonality and other things are difficult, but generally, nodal marginal zone hyperplasia is accompanied by other changes, other issues, usually seen as, most of the time, toxoplasma is the cause for marginal zone hyperplasia. So you will find granulomas, you will find follicular hyperplasias, etc. Marginal zone lymphoma, the follicular hyperplasia is not there. It's more of atretic follicles surrounded by, if it's an in situ or surrounded by marginal zone cells. So it's a tricky thing.
Expansion of the marginal zone, interfollicular,
yes, expansion.
And into
it's an expansion at the expense of the germinal center. That's lymphoma. Whereas in this, there is germinal center proliferation, and in the subcapsular area, the marginal zones are usually infiltrating.
Okay, subcapsular.
In a lymph node. In a lymph node.
That's good clue, sir. Thank you.
Thank you, sir. Another question is from Dr. Mayak Mallisway. Which IHC markers at least should be done to differentiate between reactive versus a neoplastic condition?
It depends on what reactive condition it is. Like I said, for a follicular lesion-based lesion, you will have to do a BCL2 and CD10 and maybe Ki67. If it's a follicle, apart from CD3 and CD20, identify the lineage B and T. If it's a kind of a mixed population where you're suspecting a PTCL, then yes, the entire T cell immunohistochemistry has to be done. If you're confusing it with a Hodgkin lymphoma, then yes, CD30, CD15, PAX5 has to be done. So it is all case-based. I mean, basic morphology, and then you apply your immunohistochemistry. That's what I would recommend even now with the advent of too many markers. I would still not be, I'll be still biased against the morphology. Understood? So if it's a follicular-based lesion, a certain set of markers. If it's a paracortical expansion, a certain set of markers. If you're looking at large cells amidst a background of small cells, another set of markers. So it depends entirely on what pattern and then use of markers.
Thank you, sir. Dr. Rashmi Khushpa, you have any question?
Yes, sir, actually, like what I have noticed, there is a lot of difficulty when there is necrosis associated with some atypical looking cell, and when we want to put up IHC, this necrotic areas will usually take up a lot of background staining.
Yes.
So it becomes really difficult in those situations.
Yes,
how to
it is a
interpret
common problem. It is a common problem.
Thank you.
If it is a totally necrosed node and your IHC is not working out, there's too much, I would suggest maybe sampling another node or maybe doing an FNAC of another node, which is at least will give you a cellular yield. You need good number of cells too, which will give you a clue. So it depends again on case to case. But it is a problem, definitely, when there is extensive necrosis. The IHC can be misleading.
Yes.
On the other hand, I've also published cases where you see, let's say in the marrow, we have had cases. Myelonecrosis is there, but the cells have retained some of the markers. It's called the process of necrobiosis. We have been able to pick up a few ALLs in a totally necrotic marrow because the IHC did work. Did work. So it's both ways it works. It can be a difficult thing. It could also lead you to a diagnosis.
Okay, sir.
Case-based.
There is one more question from Dr. Avinash Singh. what we should read and stress on lymph node biopsy report other than IHC markers?
No, don't Avinash, don't look at the IHC marker straight. If you have a descriptive report, I don't think you need to really bother. But from your point of view, yes, you need to have a diagnosis clear cut. You need to have what lineage it is, that is important. Just looking at IHC markers may not help you. You need to know what is a lymph node biopsy, especially with a lymphoma, from a pathologist point of view, should give you the diagnosis, should give you indicate what grade of lymphoma it is, should tell you the lineage. Because now all these, if you look at the classification, it is all disease based. It's an entity based. So you need to have the full entity with you, with all the possible connotations for the prognosis. So that is what you should look for, not a vague report like an atypical cell scene or suggestive of a lymphoma. That I'm sure will not help you. But that's what I hope you understand. You need to have it's a responsibility of the pathologist to give you all possible information, which will include the diagnosis, the immunomarkers that are of significance, and be able to tell you the risk stratification of that case.
Thank you, sir.
That is our
The
responsibility.
question is, yeah, thank you, sir. Another question is regarding always a dilemma we clinicians do have always and always when the report has been come as granulomatous lymphadenitis. Whether it is tuberculosis or sarcoid. This is a big question on what to start the treatment because treatment is entirely different. One is AKT and one is steroids.
Absolutely.
And
Absolutely.
steroid to a patient of AKT may flare up with tuberculosis.
Yes.
Any clue on biopsy? Because you already mentioned about reticulin. That point was very clear. Should we go for reticulin first and see whether this is reticulin staining, which is very marked? And
it could be, but difficult. What I would suggest a pathologist to do if you are looking at a granulomatous which are non-caseating, take multiple sections. Take deeper, if necessary, exhaust the block and identify. That is this pathognomonic change of caseation versus non-caseation. That's important. One point that you must rule out a focus of caseation at all. Then do a good, whatever, if it's a purely granulomatous, yes, maybe acid fast stain won't be positive, but screen for acid fast bacilli. Important. And though it sounds cliched, but at least even now, tuberculosis is much, much more common than sarcoidosis in our country.
So if the patient is not responding to AKT, then we can think of sarcoidosis.
Then you can think of and have a dialogue with your pathologist. I'm sure that will solve most of the issues.
Sir, will Langhans cells help, sir? Because it is not seen in sarcoidosis, right? Even it is not
said that it is
caseating.
not seen. Said that, yes, definitely those, what I discussed, these various 7-8 points are true. Are in most of the situations you look for, sarcoid has more of different types of giant cells, more giant cells than epithelioid cells. So those are there, naked granulomas. Those are definite features that tilt you towards a diagnosis of sarcoid versus non-sarcoid. But as I showed you, I saw Langerhans giant cells I've seen in so many other neoplastic conditions also. So some of it is actually in neoplastic. I showed you a case of AITL with beautiful Langerhans giant cells, non-tubercular. So these are there standard, but it is not that you can have every case of sarcoid will not show Langerhans. That doesn't work. It's a combination of findings.
If we are not able to differentiate on morphology basis, we can advise them for expert or
yes,
other
100%. Absolutely. Or the other parameters for sarcoid, ACE levels, etc., would help. Therefore, it's a dialogue. It's a
integration.
Integrated. Anything.
Okay.
Thank you, sir. Another thing, sir, another problem we clinicians always usually face is regarding case of lymphoma. PET CT scan shows end of treatment PET CT shows positivity of only one lymph node region. And we dispose the patient for IFRT. And after IFRT, about 3 or 4 weeks after IFRT, again the PET shows that active FDG lesions. The biopsy shows necrotic. So whether this necrotic lesion is there, which is big mass but necrotic, so is it a active malignancy? How to differentiate whether it is non-active or active now?
Very difficult for us. If it's entirely necrotic, I really don't know how would we call it active. If the entire is necrosis, difficult for us to label. So I don't know. Some of these you'll have to leave, I think, to God. to solve. Understand? I mean, if it's totally necrotic and I'm not seeing any remnant of the tumor, I really cannot call it a.
But
I
if
really
it
don't.
is some viable cells which are positive, what
If
is
there are definitely viable cells are there, positive for your markers, like if it's a DLBL and CD20 and follows the IHC pattern of the previous marker, then yes, of course, it could still be a residual disease which is not fully gone. Which is not fully gone. So we have to make attempts to look at it morphologically, take step sections, see if IHC helps, at least the basic IHC, yes, then definitely yes. Then I would label it as not in remission.
Thank you, sir. One question is from Dr. Jyoti Sauni. Sir, how to prove clonality on IHC when there is a referral as a T cell lymphoproliferation to a tertiary center?
Yeah, I suppose T cell receptor, gamma delta or alpha beta. That works out. That works out on IHC. Difficult, but yes, it is.
Perfect. Thank you, sir. Sir, you had already once spoken about that dermatopathic lymphadenopathy versus superficial mycosis fungoidosis.
Yes,
That's
yes.
always the DD. So how would you differentiate the two, sir?
That is where you'll have to look at the dermatopathic area, which is showing whether there are atypical cells or not. And there is the role of doing a T cell clonality assessment, CD3, CD4, CD8, and if necessary, your T cell receptors. So that is a tricky point. If you look at the staging of a dermatopathic lymph node, especially in relation to a mycosis, that is how it is described. Stage 0 is dermatopathic. It is staged also, dermatopathic, but provided you have ruled out atypical cell infiltrate. So, and that ruling out is entirely by your IHC and if necessary on T cell receptors.
So T cell receptors, IHC markers are there, sir?
No. It basically
it's not there. No. Only on flow we can do some
only on flow
beta
or,
receptor,
yes,
or we
yes.
have to go for the gene rearrangement.
Yes, definitely.
Yeah. So thank you, sir. So I finished all the questions from the chat box. Anybody has any other question over here? So in that case, sir, there are no more raising signs. No more questions in the chat box. Thank you so much for the wonderful lecture. It was a knowledge, learning, and wonderful, fantastic lecture, sir.
Yeah.
And what wonderful.
In future, don't call it a lecture, man. I hate lectures. It's a talk.
Yeah, it was so wonderful, sir. You have put entire info in all the one slide, and you have shown all the ranges in the lymph node biopsy. That was so nice to see, sir.
Thank you so much.
Thank you so much, sir.
Yeah, so I'll leave the session. Thank you and good day, all of you.
Thank you,
Time
sir.
for the Australian Open final.
Yeah.
I'm rooting for Djokovic. All time.
Thank
Thank you. Bye-bye, all of you.
Bye, sir.